Slide 18. Clinical diagnosis and epidemiology of various types of oro-facial clefts. You will find on this slide the clinical presentation of various types of oro-facial clefts commonly encountered in our practice. The incidence in Africans is not known, but it can be in the neighborhood of 1 into 1,500 to 2,000 live births. In the Caucasians, it is about 1 in 1,000, and in Asians, about 1 in 600. Left-sided clefts are said to be commoner than the right. The two common syndromic clefts are Pear-Robbins sequence and Treacher-Collins syndrome. It is a sequence rather than syndrome because it is caused by a series of events that take place in fetal development. It begins with a defect of the lower fetal jaw, abnormally small or micronatia, the tongue that becomes abnormally placed in the back of the throat, glossotosis, and in turn causes a cleft palate, that is, a hole in the palate. Treacher-Collins syndrome, that is, mandibulo-facial dysostosis, manifests as anti-mongoloid slope to the palpebral features. Deformed pinna, coloboma, anomalies of middle ear, extra ear tags, deviant malar bone, receding chin, and apoplastic condyles. These are manifestations of anomalies of first and second brachial arches. Other associated anomalies that are presented in patients seen at CAT, Ghana, include syndactyly of the left hand and left foot, diagonal polydactyly, that is, polydactyly of right hand and polydactyly of left foot. In one American study, 20% are isolated cleft lips, that is 18% unilateral and 2% bilateral. 50% cleft lip and palate, made up of 38% unilateral and 12% bilateral, and 30% are cleft palate alone. The incidence of isolated cleft palate without cleft lip is 1 in 2,000 live births. Submucous clefts are also common, with an incidence of 1 case to 1,200 to 2,000 patients. Bifid uvula occurs in 1 of 80 patients.